Bismillah ar-Rahman ar-Rahim. This is my lecture to the students of level 3, semester 5. We are going to present a lecture about seborrheic dermatitis, acne vulgaris, and miliaria. Our learning target today: how to diagnose and treat all these diseases, seborrheic dermatitis, acne vulgaris, and miliaria. I will take a basic knowledge about the etiopathogenesis of all these three diseases. Seborrheic dermatitis. It is erythematous scaly eruption localized on the sebum rich areas, characterized by greasy looking scales, and severity varies from mild dandruff to exfoliative erythroderma. Regarding the etiology, the exact pathogenesis of this disease is not fully understood, but there is a link to maturation of the sebaceous gland at puberty. That's why the onset usually occurs at puberty, with certain exceptions. The commensal yeast malassezia, Pterosporum ovale, has a role in pathogenesis of seborrheic dermatitis. The prevalence of eczematous form is estimated at 5%, which is usually more or less severe rather than the usual mild form of dandruff. Men affected more than women, and the age of onset usually, as I mentioned, at puberty, with the peak age of 40 years. It is very uncommon in pre-adolescent childhood. And in this point, I would like to stress that you have to exclude other etiology of scaly scalp, and we'll see this again. There is exception of early onset of seborrheic dermatitis, which is called infantile seborrheic dermatitis. Seborrheic sites. This is the target of seborrheic dermatitis. They are oily and hair-bearing areas of the head and the neck, like scalp, forehead, eyebrows, lash line, nasolabial folds, beard, post-auricular and auricular skin. Also the pre-sternal and interscapular areas and flexures, like the umbilicus, axilla, inframammary, inguinal fold, perineum, and anogenital crease. These pictures illustrate these seborrheic sites I just mentioned. Seborrheic dermatitis of the scalp has two pools: either the non-inflammatory type, which is known as dandruff, or the inflammatory type with the seborrheic eczema. Dandruff, or pityriasis capitis, which is the diffuse fine white briny or greasy scales without significant erythema or irritation. Scalp, beard, mustache are the usually affected, may be considered as the mildest form of seborrheic dermatitis, or sometimes a precursor of more severe form of seborrheic dermatitis. This is a typical picture of dandruff: diffuse fine white briny scales without significant erythema. Seborrheic dermatitis of the scalp, inflammatory type, on the other hand, shows red inflamed skin associated with itching, which predisposes 2. Folliculitis, furuncles, and blepharitis. Infectious eczematoid dermatitis due to secondary infection, giving the picture of oozing and crustation. This is the briny scales with background of red inflamed skin. Eczematous type of seborrheic dermatitis of the scalp. Facial skin, also common site affected by seborrheic dermatitis. Symmetric yellowish red with brown-like scales. Nasolabial folds, eyebrows, scalp margins. Non-purulent otitis externa and seborrheic blepharitis. This is the retroauricular sulcus affected with seborrheic dermatitis. Please look at the flaky, white, and grazy scales. Also, infectious eczematoid dermatitis and oozing and crustation. Here on the ear. Scalp, nasolabial fold, and bird area. Nasolabial fold, retroauricular, blepharitis also. So this is the typical features of facial seborrheic dermatitis. Another pictures. Beard and mustache area affected. On the trunk, presternal and interscapular area was a very common site for seborrheic dermatitis, localized red oval or annular grazy scales. May be sudden generalized exacerbation of the rash, which may resemble pityriasis rosea or psoriasis sometimes, and the erythroderma is rare. As you see here, the presternal area affected, chest, sometimes called petaloid type of seborrheic dermatitis, presternal area, looks like pityriasis rosea. Flexural seborrheic dermatitis, which is called inverse seborrheic dermatitis, affecting the flexures, scaling intertrigo, sharply marginated erythema and grazy scales. Non-scaling in intertrigo, maybe just erythema. Crusted fissures, weeping dermatitis with oozing and crustation, maceration, or sebopsoriasis, taking the picture of a mix of both psoriasis and seborrheic dermatitis. This is the typical picture of seborrheic dermatitis of the flexure in the axilla. Extensive seborrheic dermatitis. Sometimes seborrheic dermatitis presented to us with severe form, what's called erythrodermic, which is severe erythema and scales all over the body. It's very rare. When you see seborrheic dermatitis severe and resistant to the therapy, you have to look HIV infection. Seborrheic dermatitis extensive also is sometimes associated, or the Parkinson disease is sometimes associated with seborrheic dermatitis, extensive seborrheic dermatitis. This is very important to look at the differential diagnosis of adult scalp seborrheic dermatitis. Other than the seborrheic dermatitis scale scalp, look for or you have to exclude psoriasis. Sometimes, as I mentioned, mix of psoriasis and seborrheic dermatitis, what's called sebopsoriasis. But in psoriasis, usually the scales are thicker, silvery white, dry, brighter pink erythema in the background, and more or less well circumscribed, less pruritic, and no seborrhea. And you can look for a typical psoriatic lesion elsewhere with family history also. These are more or less differentiating points. But if you are stuck with the diagnosis, you have to reserve to differentiating maneuvers like skin biopsy, for example. Treatment of seborrheic dermatitis easily suppressed by, but usually relapse rapidly. No permanent cure. So the rule is control rather than cure. Non-scalp regions is extremely steroid responsive. So, but please avoid potent fluorinated steroid because you are going to use it for long time, and avoid aggressive topical therapy. Frequent washing with soap and water is very helpful. There are two-step regimen of treatment: initial lines and maintenance lines. Initial topical antifungal, topical steroid, or both. Make a combination of both, and steroid and antifungals. Mention here we are going to maintain, after control with the first initial lines, you can maintain your control with medicated shampoo like zinc pyrithione, tar shampoo, selenium sulfide, ketoconazole, or these could be used for maintenance. There are alternatives for this topical, like topical calcineurin inhibitors like picrolimus or tacrolimus, and sometimes plus or minus salicylic acid ointment in low concentration, 3 to 5%. In unresponsive cases, resistant cases, we can resort to ultraviolet therapy or oral antifungal, and in severe non-responsive resistant cases, we can use also oral corticosteroid, oral prednisolone in low dose 30 milligram daily. Here we are going to deal with the exception of onset of seborrheic dermatitis. As I mentioned, usually seborrheic dermatitis occurs at adolescent, but there is exception. Infantile seborrheic dermatitis. The onset of this disease begins at 2 to 8 weeks after birth, usually subside within 3 to 4 weeks, so within 1 month it usually subsides, may persist for several months. Clinical, simultaneously on the scalp, face, and in the napkin area at its onset. Scalp area, what's called scalp cradle cap, 6 scales forming yellowish brown heaped lesion. Also, there are lesions at the axilla, inguinal folds, which are very characteristic. Secondary dissemination and widespread is rare. As you can see, here is a common presentation of infantile seborrheic dermatitis on the scalp, that's called cradle cap, and sometimes on the face. This typical common presentation, which subsides usually within few weeks. But as I mentioned, sometimes infantile seborrheic dermatitis become more and more severe and extending to take the whole body, with the glistening red plaques of the neck, axilla, inguinal fold, as well penis, umbilicus, and disseminated in the trunk and extremities. These are closer views of the seborrheic dermatitis, extensive, disseminated in the abdomen, the trunk, and on the napkin area. Treatment of infantile seborrheic dermatitis: avoid irritating soup, regular use of emollients after bathing, olive oil for crust removal, mild shampoos including ketoconazole, and avoidance of medical measures. As I mentioned, it is self-limited. Ketoconazole cream once or twice daily for about 2 weeks, and sometimes combined with a low potency topical steroid for short course. Scaly tinea capitis in prepubertal children, very important to exclude these diseases. Tinea capitis, scaly type, psoriasis, seborrheic dermatitis, and pityriasis rubra pilaris. So if you see a case of scaly scalp in prepubertal skin child, you have to exclude these diseases especially tinea capitis, and you must exclude in tinea capitis in any case of scaly scalp in children. Acne vulgaris. This is our second disease today, lecture. It's a multifactorial disorder affecting the pilosebaceous unit and clinically characterized by comedones. These are the primary lesion, papules, pustules, nodules, and scarring sometimes. The age of onset is usually from 12 to 24 years mainly. Usually may start at 10 years and may persist up to 50 years. Usually there is genetic predisposition and usually familial or family history. There are 4 factors of acne vulgaris in the etiopathogenesis of this common disease. Retention hyperkeratosis of pilosebaceous duct, increased sebum production under the effect of androgen, propionibacterium acne within proliferation within the follicle, and inflammation initiated by this bacterial proliferation. There is infundibular keratinocytes, excessive proliferation, increased cohesiveness of the keratinocytes, retention hyperkeratosis, and formation of hyperkeratotic plaque, what's called microcomedones. This is the starting point. As you see here, these are the very minute beginning or starting point formation of these microcomedones. Under the effect of androgen, there is excessive sebum production, and plus the formation of microcomedone. There is accumulation of loosely packed shed keratinocyte and the sebum. Okay, and this gives anaerobic media, which is a good environment for formation of or proliferation of propionibacterium acne. You will see here the comedones. Comedones, as I mentioned, is hyperproliferation of the keratinocyte leading to plaque of the opening of the pilosebaceous unit. If it is under the surface of the skin and white colored, it's called closed comedone or whiteheads. If it is on the surface of the skin, it's called black colored or blackhead or open comedone. So open comedone are blackheads, and white heads are closed comedone. Overgrowth of propionibacterium acne in this suitable media, anaerobic media, leading to formation of free fatty acids and formation of many inflammatory mediators like tumor necrosis factor alpha, and attraction of neutrophils and others, formation of the pustules. And if this leads to accumulation or over accumulation of these collections, it leads to rupture of the hair follicles and formation of the nodules. Exacerbation factors, diet. Till now there is no document about the effect of diet on the acne. But recent studies claim that Western diet with high glycemic index as white rice, cornflakes, and potato chips, and also excessive consumption of milk, not cheese, may exacerbate acne. Other exacerbating factors, premenstrual flare may occur in 2 or 5 days before the menses, the monthly menses. Sweating is an exacerbating factor, and emotional stress, of course, is an exacerbating factor. Acne vulgaris clinical picture, it's comedone. It is the pathognomonic lesion of the acne vulgaris comedone, either open, it's called blackheads, or closed, it's called whiteheads, plus papules, pustules, nodules, cysts, which are not true cysts, scars sometimes, red macules representing regressing lesions. So it is polymorphic lesion. Polymorphic means many lesions, many features. Comedone, papules, pustules, nodules, cysts, scars, red macules, sites. Face and the neck is the common site, but sometimes it affects the back, chest, shoulders, upper arms. Classification: in mild acne, only comedones plus little or few papules. Moderate, the dominant lesions in addition to the comedones and papules are pustules. So comedones, papules, and pustules. Severe acne, the dominant lesion here is nodules, in addition, of course, to others like comedones, papules, and pustules. So if you see the comedones dominantly, this is mild acne. If you see the comedones in addition to papules and pustules, and the pustules here are dominant, this is moderate. In severe, the dominant lesion, in addition to other lesions, the dominant are nodular lesion. Okay, well, now we're going to take a tour of pictures of different grades of acne. Here the open comedones, as I see, the blackheads here is the dominant feature here, as you see here. By the way, these black comedones in the external ear are not dirts, they are just black comedones. Open heads, open comedones or blackheads. Closed comedones, skin colored, not visible follicular opening, often inconspicuous, and require adequate lighting and stretching of the skin to see. These are the closed comedones, skin colored or white heads. As you see here, some comedones black and white, and here you can see tiny atrophic scars. Here are comedones, open blackheads and closed whiteheads. Comedones, inflamed papules, and few pustules. Here starting to see some pustules. So this is moderate case of acne. Here typical moderate case of acne, because the dominant lesion here is pustules. So you can see, in addition to the pustules, also some papules, some comedone, but the dominant lesion here is pustules. So this is moderate case of acne. Still, papules and pustules are the dominant lesion, so this is moderate case of acne also. Moderate case, another moderate case. Pustules, as you see here. Oh, so the dominant lesion here are nodules. So this is, you are right, this is severe case of acne, because the dominant lesions here are nodules. Appearance of the nodules here settles the case as severe case. As you see here, polymorphic lesion, comedones, papules, nodules, pustules. So as you see here, this is severe case of acne. Resolution usually at the age of 25 to 35. Acne sequelae. A big question, why you are treating acne? To avoid the sequelae. So our point, to avoid scars, to avoid persistent post-inflammatory hyperpigmentation and post-inflammatory erythema, because these are disfiguring sequelae of the acne, and our concern is to avoid these complications or sequelae. Of course, by proper treatment. Pitted scars, as you see here, pitted scars, atrophic scars. This is these disfiguring scars are complication of improper treatment of acne. Also, what's called ice pick scars. These small pitted scars on the face, one of the sequelae of acne. Let us go to the different lines of therapy. Inhibition of follicular hyperkeratosis by comedolytic agent. Inhibition of propionibacterium acne by topical benzoyl peroxide or topical antibiotics and systemic antibiotics. Inhibition of sebum production by anti-androgen and isotretinoin, and of course anti-inflammatory. Topical treatment, comedolytic. Topical retinoids is the cornerstone of acne treatment, plus minus salicylic acid to 2%. So the cornerstone of treatment of acne in topical lines is topical retinoids. Antibacterial also has a very important role, especially benzoyl peroxide with different concentrations ranging from 2.5, 5, 10% and 10%, no resistance. And also it has mild comedolytic effect, but sometimes it is irritant. Antibiotic, erythromycin, clindamycin. Sometimes there is combination of benzoyl peroxide and antibiotic, and this combination increase the efficacy and decrease the resistance, plus azelaic acid. Topical treatment used alone in comedonal acne, topical retinoids, as I mentioned, or mild inflammatory acne, a combination of antibiotic and topical retinoids. With oral treatment in moderate to severe acne vulgaris. So in moderate and severe, we have to add oral treatment. Maintenance treatment after stopping oral treatment. Topical retinoids are the cornerstone of treatment of acne. Tretinoin with different concentration alone or in combination with clindamycin. Also, there are different preparations like adabalin, isotretinoin, or tazarotene. Systemic treatment in acne vulgaris, with which we have to add in moderate and severe forms, oral antibiotics, anti-androgens, and isotretinoin. Oral antibiotics, tetracyclines, like aminocycline, doxycycline, erythromycin, azithromycin also, clindamycin. Mechanism of action is the reduction of the inflammation by reducing the propionibacterium acne proliferation, reducing bacterial production of inflammatory factor as free fatty acids and interleukins, and entrenching anti-inflammatory effect, reduce the polymorph nuclear migration. Anti-androgens, it's used only in females, not in males. in severe acne. And in females also, especially in married females in childbearing period, you have to add contraceptives. It's present in some contraceptive like Diane in combination with cyproterone acetate, and also in spironolactone, which is aldactone. It is diuretic, but here we are not using it as a diuretic, but as an anti-androgen. Also, some contraceptives has anti-androgen effect, like Yasmin. Isotretinoin. Isotretinoin is a magic line of therapy in severe acne, because it acts in all lines of pathogenesis of acne. It decreases the sebum production, decrease propionibacterium acne, decrease follicular hyperkeratosis, and it has anti-inflammatory effect. But this line of therapy not allowed to be prescribed except with a specialist at least, because it has to be under supervision and investigation before and during the therapy, for monitoring of the lipid profile, the liver enzymes, and of course you have to avoid it in any woman childbearing period, except with at least two contraceptive methods, because it is definitely teratogenic drug. So it is very effective, but must be prescribed in certain patients with certain meticulous precautions. Other line of therapy, like comedonal removal in resistant comedones, or intralesional steroid, diluted steroid, and very effective in some patients, but also it is restricted to be used only with very well-trained dermatologist, specialist, or consultant. Treatment of scars. These are the sequelae. As I told you before, our concern of therapy of acne is to avoid the sequelae, to avoid the complication. But if it happens, what are we going to do? These are aesthetic measures like dermabrasion, laser resurfacing, deeper chemical peels, filler-resistant substances, pans excision and ice pick for ice pick scarring, and others. These are maneuvers we can employ for improving the appearance of these disfiguring scars. This is the overview of therapy in mild acne: topical retinoids for comedones, plus minus benzoyl peroxide if mild inflammation is present. Moderate topical retinoids plus oral antibiotic, plus minus benzoyl peroxide to reduce antibiotic resistance, plus minus anti-androgens in females. Severe acne, isotretinoid is the line of choice. Miliaria or sweet rash. This is the histology of sweat glands. As you see here, it's like a coil in the deep dermis at the junction of the dermis and the subcutaneous fat, and it is connected to the surface epidermis by a tube or duct to be open on the surface epidermis. The idea of miliaria is obstruction of the eccrine glands, eccrine duct, this tube which open on the surface at various levels. leading to sweat retention. So miliaria is sweat retention due to obstruction of the eccrine duct at different or various levels. It's common in neonate because the immature eccrine sweat glands, but adults, of course, who are living in hot humid conditions, children and adults who are living in hot humid conditions are very vulnerable, are susceptible to this very common disease. Resolve, of course, in cool environment. Miliaria key features three types. There are three types according to the level of obstruction of the eccrine sweat gland, sweat duct. So the obstruction of sweat duct, if it is superficial, leading to clear vesicle, this is called miliaria crystallina. If the obstruction of this duct intermediate, this is called miliaria rubra, and the result here will be erythematous papule and pustules, not vesicles. Sometimes, but the dominant here are papules and pustules. Miliaria profunda, this is deep ductal obstruction, and the result will be white papules. So if you see the dominant lesion vesicles, this is miliaria crystallina, and this means that the obstruction is superficial, ductal obstruction or occlusion. If you see it is white papules, so the obstruction here is deep ductal obstruction. Between superficial and deep, intermediate ductal obstruction, this is the miliaria rubra, presented with erythematous papule or pustules. Precipitating factor, hot humid condition, excessive clothing, obesity, febrile illness. The lesion usually closely set red papules and vesicles. Pinhead sized, itchy or breaky and burning sensation may be generalized in infant, and the site, any site could be affected. Complication due to the itching, impetigo and folliculitis, very common complications. This is the typical picture of miliaria rubra. As you see here, discrete, minute, erythematous papule here on the trunk, on the back here. Very pricky, very irritating. As you see here in the infant, you can see miliaria rubra on the face. And if you see some pustules in the face also, in addition to the erythematous papules, these are pustules in what's called miliaria pustulosa. These are sterile pustules, not infected. Treatment, the cornerstone of therapy in our case of miliaria is air conditioning. One title is air conditioning. So avoidance of excessive clothing and tight clothing, occlusive ointment is mandatory. You can add vitamin C, you can add soothing agent like calamine lotion, you can use antibacterial soap to avoid secondary bacterial infection, but still the main line of therapy is air conditioning. Thank you very much.